Welcome to the Deep Dive series, the Rad-Onc Smart Review GI Cancer series. We're here to take these sometimes really complex topics and just break them down into the essential, actionable knowledge you need.
Exactly.
Today, we're starting a really crucial journey, Esophagus Part 1. We're focusing right in on the absolute foundations, the anatomy, the staging process, and the surgical options. You know, these are the building blocks for everything else.
They really are.
When you first get an esophageal cancer case, it can feel, well, a bit overwhelming, maybe like trying to untangle a knot.
Mm-hmm. Yeah.
But understanding these fundamentals, the basic structure, the latest AJCC staging, the whole surgical landscape, that's what helps us untie that knot. It really drives those initial clinical decisions way before we even start thinking about radiation fields.
That's absolutely right. And for you, as residents working through these cases, getting these fundamentals really dialed in is, well, it's paramount.
Right.
Think about it like this. That unique anatomy. It's not just, facts for a test. It dictates exactly where our treatment fields need to go and, critically, where we expect the disease to spread. Understanding staging isn't just about assigning a number. It's the compass. It guides us to the right modality, surgery, chemo, radiation, or often some combination.
Makes sense.
And knowing the surgical approach, what the patient had or what they might have, that's crucial. It helps us anticipate toxicities, lets us tailor our radiation plans super carefully. So yeah, this session is all about building that interconnected understanding so you can make confident decisions from day one.
Okay, great. Let's dive in then, starting with the very basics, the esophagus itself, because its structure really sets the stage for everything else.
It does.
So essentially, it's a muscular tube, and it's surprisingly long, actually, about 25 centimeters in an adult.
Yeah, people often underestimate the length.
Right. So try to picture it extending from the cricopharyngeus muscle, kind of right behind your voice box, all the way down to the stomach. And clinically, we rely on some pretty standard landmarks, measured from the incisors, the front teeth.
Yep, always from the incisors.
So for instance, the cricoid cartilage, that's a key landmark, marks the start of the thoracic esophagus, usually around 15 centimeters.
15 centimeters, yeah.
Then further down, a really critical one, especially for things like bronchoscopy, is the carina, where the trachea splits.
The bifurcation.
Exactly. That's typically around 25 centimeters from the incisors.
25, got it.
And finally, the GE junction, gastroesophageal junction, where the esophagus meets the stomach, that's usually down around 40 centimeters.
40 centimeters, so quite a range.
Yeah, quite a journey. And this geography naturally divides it up. You've got the cervical esophagus, maybe 15 to 20 centimeters.
It's the neck part.
Right. Then the thoracic esophagus, which is the longest bit, and where most cancers happen, we usually break that down further upper, middle, lower thirds, just for better localization.
Yeah, it helps with planning.
And then there's that short little abdominal esophagus just below the diaphragm before it hits the stomach.
Yeah.
So yeah, top to bottom, it's a long path for food and, unfortunately, for cancer, too.
What's really fascinating here, and this is a critical point, you absolutely have to remember this,
Right.
is something totally unique about the esophageal wall. Unlike the stomach or the colon, they have that tough outer layer, the serosa.
Yeah, that protective coating.
Exactly. Well, the esophagus, it just doesn't have it. It completely lacks a serosal layer.
Wow. Okay. So what is the outermost layer then?
It's just adventitia, which is, well, it's much looser, kind of flimsy connective tissue, not that robust membrane you see elsewhere.
So like a pipe without the outer casing.
That's a great analogy, actually. Imagine, a building without its outer protective shell, or like you said, a pipe without that tough casing. It's just much more vulnerable.
Okay, and the implication?
The implication is huge. It means there's a much lower barrier to local invasion. Tumors can just push right through into adjacent structures, the aorta, the vertebral bodies, the trachea, way more easily than, say, a colon cancer might.
Gotcha. That makes T-staging critical.
Absolutely critical. When you're looking at scans, you're not just finding the blob, you're meticulously checking that interface. Is there a fat plane? Is it lost? Is there direct involvement? Because that tiny detail changes the T-stage, changes resectability. It's a total game changer.
Okay, wow. Lack of serosa, big deal.
Huge deal. And that's not the only anatomical quirk giving us headaches.
Oh, yes.
The lymphatic network. The esophagus has this incredibly rich, longitudinally oriented network of lymph channels right there in the submucosa.
Longitudinally, meaning up and down.
Exactly, running the length of the esophagus. And this isn't just, an interesting anatomical fact. It has profound clinical consequences you'll see all the time.
Like what?
Like early and extensive skip metastases.
Skip metastases, meaning they jump over nearby nodes.
Precisely. Cancer cells can literally bypass the immediately adjacent lymph nodes and travel much further up or down the mediastinum. They can pop up in supraclavicular nodes way up high or celiac nodes way down low, even when the nodes right next to the tumor look clean.
Wow. So you can't just assume local spread.
You absolutely cannot. I remember a case, early training, mid-esophageal tumor, looked pretty contained locally on the scans, but then boom, positive supraclavicular node found on workup. That's a skip net, a direct result of this lymphatic highway.
So that makes nodal staging really challenging.
Incredibly challenging, and it's why a thorough lymph node dissection during surgery is so important, and why our radiation fields often have to be pretty darn long to cover those potential skip areas. You got to think longitudinally.
That structural vulnerability, the lack of serosa, and then this lymphatic superhighway, it really paints a picture of why esophageal cancer can be so tricky.
It absolutely does.
Okay, so moving from the structure to the actual cells that go bad, the pathology, we mainly see two types, right?
That's right. Two main histologies dominate. First, you've got squamous cell carcinoma, SCC.
Okay, and the risk factors for that one.
Classic ones. Heavy smoking, chronic alcohol use. Those are the big drivers for SCC. And location-wise, it tends to favor the upper and middle thirds of the esophagus.
Got it. Smoking, alcohol, upper middle thirds.
Yep. It used to be the most common type worldwide and still is in many places.
Okay, and the second type?
Adenocarcinoma. And this one tells a different story, especially here in the US and other Western countries.
How so?
The main links here are chronic GERD, that persistent heartburn, which can lead to Barrett's esophagus, a premalignant change.
Right, Barrett's. We hear a lot about that.
Exactly. And obesity is another major independent risk factor, often tied in with the GERD picture.
And location for adenocarcinoma.
Typically distal esophagus and, critically, the GE junction, right where the esophagus meets the stomach.
And you said it's more common now in the U.S.?
Yeah, there's been a huge epidemiological shift over the last few decades. Adenocarcinoma is now the most common type we see here, surpassing SCC, which makes that GE junction area even more important clinically.
Because you need to figure out if it's truly esophageal or gastric.
Precisely. And that's where the SIRT classification becomes absolutely essential. You have to know this.
Okay. Tell us about SIRT.
It's all about determining whether to manage the cancer as esophageal or gastric, especially for those tumors right around the GE junction. And it all comes down to one thing: the tumor's epicenter, its central point.
Got it. Epicenter location.
Yep. So SIRT type 1, the epicenter is 1 to 5 centimeters above the GE junction. Clear cut. Treat as distal esophageal cancer.
Okay. Type 1, above the junction.
SIRT type 2. Epicenter is within 1 centimeter above to 2 centimeters below the GE junction. This is your true cardiotumor right at the junction. Typically, we manage these as esophageal, but there can be some debate.
Okay. Type 2, right around the junction, mostly esophageal.
Right. And then SIRT type 3. The epicenter is from 2 to 5 centimeters below the GE junction. So it's starting in the stomach, the subcardial region.
Okay. More than 2 centimeters below.
Exactly. And according to the latest AJCC 8th edition guidelines, these type 3 tumors, they are staged and treated as gastric cancers, period. Even if they grow upwards and invade the GE junction or distal esophagus.
Ah, so that's a hard rule now. Epicenter 2 centimeter below is gastric?
It is.
Yeah.
And here's a simple way to remember it, like a quick mnemonic. Focus on that 2 centimeter mark. If the tumor epicenter is more than 2 centimeters into the stomach, just think gastric cancer. Stage it gastric, manage it gastric.
That's helpful. The 2 centimeter rule, definitely a keeper.
It'll save you on boards and in clinic.
Okay, so we have the anatomy, the pathology, the SIRT classification. Now, how do we actually work up a patient and figure out the stage?
Right, the workup and staging process. This is where we gather all the pieces to build the treatment plan. NCCN guidelines lay it out pretty clearly. Starts with the basics, of course.
History, physical exam, labs.
Yep, looking for those classic symptoms: weight loss, trouble swallowing, any palpable nodes, standard labs to check overall health, and then critically, the EGD.
Esophagogastric-duodenoscopy.
Right. Got to see the tumor, got to get that biopsy for confirmation and histology. The EGD also gives us that initial location relative to the incisors.
Okay. What about looking for spread? Distant staging.
Absolutely vital. You need to rule out METs. Standard is a CT scan, chest and abdomen with contrast. Gives you the big picture anatomy.
But we use PE scans too, right?
Oh yeah. PT-CT is standard of care for distant staging. It's just much more sensitive than CT alone, especially for picking up small but metabolically active nodes or distant mets that might look normal on CT. You really need the PET to be confident about the M stage.
Catches things CT might miss.
Exactly. But here's where it gets interesting. For local regional staging, the T stage, depth of invasion, and N stage, regional nodes CT and PT aren't actually the best.
Ooh, what is?
Endoscopic ultrasound. EUS. EUS is king for local staging. It's just way better than CT.
Really? How much better?
There was a big meta-analysis, Rosh, showed EUS has about 85% accuracy for T staging, 75% for N staging, both significantly better than CT, which really struggles with seeing those fine wall layers and small nodes right next to the tumor.
85% for T, 75 for N? That's impressive.
It is. And if you add fine needle aspiration, FNA, during the EUS for suspicious nodes, that's the most accurate local regional staging method we have, period. You get actual tissue confirmation.
US with FNA. Gold standard for local staging.
You got it. And one more critical piece of the staging workup, especially depending on location.
Let me guess. Bronchoscopy.
Bingo. Mandatory for any tumor at or above the carina. Remember that 25-centimeter mark?
Right. Why mandatory?
Because the trachea is right there, you absolutely have to rule out airway invasion. If that tumor is invading the trachea or main bronchus, that makes it a T4B.
And T4B means?
Generally unresectable. Completely changes the treatment plan from surgery to a non-surgical approach, usually definitive chemoradiation. You cannot miss airway invasion.
Wow. Okay, T4B is a huge distinction. That leads perfectly into the AJCC staging details. 8th edition, right?
Right, 8th edition. And key point. It has separate prognostic stage groups for squamous cell and adenocarcinoma now, reflects their different biology.
Okay, let's break down the T stage, depth of invasion.
Yep. Starts with TIS, high-grade dysplasia, carcinoma in situ, cancer cells, but haven't broken through the basement membrane, confined to the surface.
Okay, TIS, earliest stage.
Then T1A, tumor invades the lamina propria or muscularis mucosae, still very superficial. Sometimes these can even be taken out endoscopically, EMR or ESD.
Avoiding big surgery potentially.
Potentially, yes, for carefully selected cases. But then comes T1B. This is a critical distinction.
Right, critical.
T1B means invasion into the submucosa, just that next layer down. But the difference, T1B tumors have up to a 20% risk of lymph node mets.
20%. Okay, that changes things.
Totally changes things. T1B generally means you need a full esophagectomy, not just endoscopic resection. That jump from T1A to T1B is huge, prognostically and therapeutically.
Got it. T1A versus T1B, check the submucosa. What's next?
T2 tumor invades the muscularis propria. That's the main thick muscle layer of the esophagus wall.
Okay, T2 into the main muscle.
T2 tumor invades through the muscularis propria into the adventitia, that outermost loose connective tissue layer we talked about.
Wait, the layer that's there instead of a serosa.
Exactly. And then T4 is invasion of adjacent structures. T4A means invading things that are potentially resectable, like the pleura, pericardium, diaphragm. Surgery might still be on the table.
Okay, T4A, resectable structures.
But T4B means invasion into unresectable structures, like the aorta, a vertebral body, or the trachea, as we mentioned.
And T4B takes surgery off the table.
Generally, yes. It signifies unresectable disease locally. So that T4A versus T4B distinction, often made based on EUS and CTPE, is absolutely paramount for surgical planning.
Okay, that T staging is intricate but makes sense. What about end stage? Nodal status.
End stage, thankfully, is a bit simpler in AJCC 8th. It's based just on the number of involved regional nodes. N0 is no nodes, N1 is 1-2 nodes, N2 is 3-6, N3 is 7 or more.
Just the number, not the location for the N category itself.
For the N category itself, just the number determines N1, N2, N3. However, and this is really important, however, the definition of what counts as a regional node for thoracic esophageal cancer is incredibly broad.
How broad?
Super broad.
Yeah.
It extends all the way from the supraclavicular nodes up in the neck, down through the entire mediastinum, paratracheal, hilar, subcarinal, paraesophageal, and clear down to the celiac axis nodes in the upper abdomen.
Wow, neck to belly, basically.
Pretty much. It reflects that longitudinal lymphatic drainage we discussed. Those skip mets can happen anywhere along that path.
So implications for treatment.
Means surgeons need to do a really extensive lymph node dissection to accurately stage. And for us in radiation oncology, it means our target volumes often need to be quite comprehensive to cover those potential drainage bases. You can't just treat the tumor plus a tiny margin.
Right. Got to respect that lymphatic spread.
Yeah.
Okay, so that sets the stage for treatment decisions. Let's talk surgery. For patients who are candidates, what are the options?
Okay, surgery. Historically, it's been the cornerstone for cure and fit patients with resectable disease. Still is, often in combination with other therapies now.
And the choice of operation depends on.
Mainly tumor location and, honestly, surgeon preference and experience. These are complex operations. We generally talk about three main approaches.
Okay, what's the first?
The transhiatal esophagectomy, the HE. This one uses incisions in the abdomen and the neck. Crucially, it avoids opening the chest, no thoracotomy.
Ah, avoids the chest opening. Advantage.
Fewer pulmonary complications, potentially. Big plus for patients with bad lungs or other comorbidities.
Disadvantage.
The big one is a very limited thoracic lymph node dissection. The surgeon's kind of working blind in the chest through the hiatus in the diaphragm, so you don't get as many nodes out from the chest, which could impact staging and maybe control, especially for mid-esophageal tumors.
Okay, transhiatal. Less lung morbidity, less nodal dissection. What's next?
The transthoracic esophagectomy, or TTE. Usually we mean the Ivor-Lewis procedure.
Ivor-Lewis. Heard that one a lot.
Yeah, it's very common. This involves a right thoracotomy, opening the chest, plus a laparotomy, opening the abdomen.
So bigger operation than transhiatal.
Definitely. It's generally considered the gold standard, especially for tumors in the lower and middle thirds.
Why the gold standard?
Because it allows for a formal, extensive two-field lymph node dissection. Surgeon can see everything in the chest and abdomen, really clear out those nodal basins thoroughly. Better staging, potentially better oncologic outcome.
Makes sense. Downsides. Besides being a bigger operation.
Well, the risks that come with opening the chest. More pulmonary issues, effusions, pneumonia. And the big fear with any esophagectomy, but maybe slightly higher here, is an anastomotic leak.
Where the connection breaks down.
Exactly. Where the stomach tube they create is sewn to the remaining esophagus. If that leaks, it's a major, potentially life-threatening complication. Chylothorax, lymphatic fluid leak is another possibility.
Okay. Ivor-Lewis.
Yeah.
Good dissection, more potential morbidity. What's the third option?
The McEwen esophagectomy. You can basically think of it as a 3-incision Ivor-Lewis.
3 incisions. Where's the third?
Adds a neck incision to the right thoracotomy and laparotomy.
Why the neck incision?
It allows the surgeon to make the anastomosis, that connection, much higher up, usually in the neck. This is useful for mid or upper thoracic tumors where you need to resect more esophagus proximally.
Okay, so McKeown for higher tumors needing a high anastomosis. Any specific risks with that neck part?
Yeah. Risk to the recurrent laryngeal nerve in the neck, which can cause vocal cord paralysis, hoarseness. But it also allows for a potential 3-field lymphadenectomy, abdomen, chest, and neck nodes.
Okay, 3 main approaches. Transhiatal, Ivor-Lewis, McKeown. Different access, different node dissections, different risks.
Exactly. But regardless of which one is chosen, transhiatal, Ivor-Lewis, McKeown, the single most crucial aspect, oncologically speaking.
Let me guess. The lymph node dissection itself.
You got it. The quality and extent of the lymphadenectomy. Removing and examining those regional nodes. NCCN actually recommends a minimum of 15 lymph nodes should be removed and looked at by pathology.
15. Why that number?
It's based on data showing that examining at least 15 nodes is needed for accurate staging. Get fewer than that, and you might be understaging the patient, missing positive nodes. It impacts prognosis and decisions about needing more treatment, like adjuvant therapy.
So if you see a path report with, say, only 10 nodes examined,
that's a potential red flag. It warrants a discussion. Was the dissection adequate? Are we confident in this end stage? It's really a quality metric for the surgery.
15 nodes.
Yeah.
Another key number to remember. Okay, so surgery has been central, but things have changed, right? Systemic therapy came along.
Absolutely. The whole paradigm shifted. Surgery alone often wasn't enough for locally advanced disease. And a truly landmark trial that brought perioperative chemotherapy into the mainstream, particularly for gastric and GE junction adeno, was the MAGIC trial.
MAGIC. Published in NJM 2006, right?
That's the one. A real game changer. It was one of the first big trials to really test chemo around the time of surgery for these cancers.
What was the design?
Pretty straightforward, actually. Patients with resectable gastric or GE junction adenocarcinoma were randomized.
Yeah.
Arm 1, surgery alone, the standard at the time.
Okay. Arm 2.
Arm 2 got chemotherapy before surgery and after surgery. 3 cycles of ECF beforehand, then surgery, then 3 more cycles of ECF afterward.
ECS, that's epirubicin, cisplatin, and fluorosil.
Yep, 5-FU. The idea was hit the tumor before surgery to shrink it, maybe make resection easier, and then clean up any microscopic cells left behind afterwards. Perioperative approach.
And the results? Did it work?
It absolutely worked. It was practice affirming, really cemented the role of systemic therapy. The 5-year overall survival jumped significantly, went from 23% with surgery alone.
Wow, only 23%.
Yeah, sobering number. But with perioperative ECF, it went up to 36%.
23 to 36%. That's a pretty substantial improvement.
Huge improvement. Really validated adding chemo, but, and this is a really important but.
There's always a but with these big trials, isn't there?
Almost always. The but here was toxicity and compliance. That ECF regimen, it was tough. Lots of nausea, vomiting, fatigue, low blood counts, mouth sores.
Sounds rough.
It was. And because of that, compliance was a major issue. Get this. Only 42% of patients in the chemo arm actually finished all 6 planned cycles.
Less than half.
Yeah. Less than half got the full intended treatment dose, mostly because they either couldn't tolerate post-op chemo or had complications preventing it.
So, a proven survival benefit, but hard to actually deliver the full course in practice.
Exactly. And that poor compliance, that difficulty giving the post-op chemo, it wasn't seen as a failure of the trial, but as a really crucial insight.
How so?
It strongly pushed the field towards investigating neoadjuvant approaches, meaning give all the systemic therapy before surgery.
Get it all done up front when the patient is stronger.
Precisely. The thinking was maybe we can get better compliance, deliver more of the intended therapy, and maybe even see better tumor downstaging if we give it all before the major surgical hit. MAGIC really helped spur that whole shift towards neoadjuvant chemo or chemoradiation, which we'll definitely talk more about next time. It set the stage for future trials like CROSS.
Fascinating how a trial's limitations can actually drive the next wave of research.
Okay.
Let's shift gears slightly. Time for some clinical pearls, those quick, high-yield takeaways. You want to start us off?
Sure. Pearl number 1. Never, ever forget the esophagus laxa serosa. That anatomical vulnerability is key. It means easy local invasion. Always scrutinize those tumor structure interfaces on imaging. It dictates T-stage and resectability.
Got it. Laxa serosa equals, well, easy invasion. My turn. Pearl number 2. Master the SIRT classification, especially for GE junction tumors. Use that 2-centimeter rule epicenter more than 2 centimeters below the GEJ means you stage and manage it as gastric cancer. Crucial for boards in clinic.
Absolutely. Pearl number 3. For local regional staging T and N stage, trust your endoscopic ultrasound. EUS, especially with FNA, is superior to CT. It gives you the most accurate picture of wall invasion and nodal status, driving treatment decisions. Don't underestimate its power.
Right. EUS is king locally. And wrapping up the pearls number 4. Remember the MAGIC trial's double message. Yes, it proved systemic therapy helped survival, but its toxicity and compliance issues were pivotal. They weren't failures, they were the catalyst for developing the neoadjuvant strategies that are standard care today. It shows how we learn and adapt.
Well said. It's all about that evolution.
Okay, great pearls. Now, we've focused heavily on anatomy, staging, and surgery today. We haven't talked much about radiation therapy techniques specifically.
Right, and that's intentional for this first part. Radiation is obviously a huge component of esophageal cancer management, but we really wanted to lay this groundwork first. You need to understand the anatomy, the staging, the surgical context before you can really grasp why and how we use radiation.
Makes sense. Build the foundation first.
Exactly. But don't worry, we will absolutely be diving deep into specific RT techniques, IMRT, VMAT, maybe SBRT in some contexts, brachytherapy, protons, all of that is coming up in future discussions. We'll cover dose, volumes, toxicity, the whole 9 yards once we have this initial framework solid.
Perfect. Looking forward to that. But for now, ready for a board blitz.
Let's do it. Hit me.
All right. Listeners, pause after the question, think it through, then we'll break it down. Case 1. 65-year-old man, dysphagia. EGD finds a big ulcerated mass. Biopsy confirms adenocarcinoma. CT scan shows the tumor epicenter is 3 centimeters distal to the GE junction, clearly in the stomach, but it is invading back up into the distal esophagus. What's the SIRT classification and how should this be staged and managed? A, SIRT type 1 manages esophageal. B, SIRT type 2 manages esophageal. C, SIRT type 3 manages gastric. D, SIRT doesn't apply.
Pause. Okay, the key here is that epicenter location. 3 centimeters distal to the GE junction. That's more than 2 centimeters below.
Right.
So that immediately tells you it's a SIRT type 3. And per AJCC 8th and NCCN, type 3 tumors, regardless of proximal invasion, are staged and managed as gastric cancer. So the answer is C.
Perfect reasoning. It's all about that epicenter 2-centimeter rule. Okay, case 2. 58-year-old woman, mid-esophageal mass, confirmed squamous cell carcinoma. She gets an EUS for staging. The report says the tumor invades through the submucosa and into, but not through, the thick, dark fourth layer of the wall. No suspicious nodes seen. What's the
Yes.
clinical T stage? A, T1A, B, T1B, C, T2, D, T3.
Pause. All right, thinking about the EOS layers, that fourth hyperchoic dark layer, that corresponds to the muscularis propria.
The main muscle layer.
Exactly. The question says invasion into but not through it. That, by definition, is a T2 lesion. Invasion into the muscularis propria.
So C is the answer. What would the others be on EUS?
Right. T1A would be confined to the first couple of layers, mucosa. T1B would be invasion into the submucosa, which is typically the third brighter layer before the dark muscle layer. And T3 would be invasion through the muscularis propria into the adventitia, the layer beyond the dark muscle. So into but not through the fourth layer is classic T2.
Excellent EUS correlation.
Okay.
Last one. Case 3. Patient has locally advanced esophageal cancer seen on EGD at 20 centimeters from the incisors. Which of these diagnostic tests is not routinely indicated as part of the initial workup? A, bronchoscopy, B, laparoscopy, C, PD, CTD, endoscopic ultrasound.
Pause. Okay, 20 centimeters from the incisors. Where does that put the tumor?
15 is cricoid, 25 is carina, so 20 is upper thoracic esophagus.
Right, upper thoracic, well above the diaphragm. Now let's look at the options. Bronchoscopy, mandatory for anything near or above the carina to rule out airway invasion. So A is indicated.
Okay. PET-CT,
Standard for distant staging, definitely indicated. So C is in.
US.
Standard for locoregional T and N staging. So D is indicated.
That leaves.
Laparoscopy. Option B, what's laparoscopy used for?
Looking for peritoneal spread, usually for lower esophageal or GE junction tumors.
Exactly. With an upper thoracic tumor at 20 centimeters, peritoneal spread is extremely unlikely. So laparoscopy is not routinely indicated here. The answer is B.
Wow. Great logic. Walking through the indications based on location. That wraps up the board blitz, really solidifies those concepts.
Good cases. They hit the key points.
Let's circle back briefly to that magic trial point.
Mm-hmm.
Those toxicities, the compliance issues. It really highlights attention, doesn't it? Proven benefit, but tough to deliver.
It really does. And it's fascinating how those practical challenges didn't derail the concept of systemic therapy, but actually refined it. It forced the field to say, okay, this helps, but how can we do it better? How can we make it more tolerable, ensure more patients get the full benefit?
Right. It wasn't a failure, it was a learning opportunity.
Exactly. It was a crucial insight that directly fueled the drive towards neoadjuvant therapy, giving chemo or chemoradiation before surgery. It's a perfect example of that continuous questioning and refinement that really defines oncology. We see a problem even within a successful trial, and we innovate. And that whole evolution really sets us up perfectly for our next discussion on definitive chemoradiation and other modern standards.
It does. And looking even further ahead, makes you wonder, doesn't it? With all the complexity in staging and surgery, how might things like emerging biomarkers, ctDNA, MRD detection change things even more?
Oh, absolutely. That's the next frontier.
Could we get even better at selecting patients? Knowing who really needs that intense neoadjuvant therapy versus who might do well with surgery first, or maybe even less treatment overall.
That's the hope. More personalized, more precise treatment selection based not just on stage, but on the tumor's biology and response. It's a really exciting time, a provocative thought for everyone listening to consider.
Definitely something to keep an eye on. Okay, let's summarize today's deep dive. We laid some really crucial groundwork, covered the critical anatomy, especially that lack of serosa,
Super important.
dove into the nuances of T-staging, the separate SCC versus adeno staging, and reviewed the main surgical approaches, Tranchiatal, Ivor-Lewis, McKeown, their pros, cons, and complications.
And don't forget, Cyric, master that classification, use the 2-centimeter rule for GE junction tumors. And remember, EUS with FNA is your go-to for accurate locoregional staging. Those are absolute bedrock principles. Get those right first.
Right. And we discussed the MAGIC trial, how it established the benefit of systemic therapy, but also, through its challenges, really pushed the field towards the neoadjuvant approaches we rely on so heavily now.
Exactly. And all this foundational knowledge, the anatomy, the staging, the surgery, the early systemic therapy trials, it's absolutely essential for understanding the why behind definitive chemoradiation and the other landmark trials that establish current standards, which is exactly where we're headed next time.
Perfect setup. To deepen your understanding and really test yourself, make sure to complete practice oral boards over at radonsmartlearn.com.
Yeah, great practice over there. And be sure to subscribe to Radonc Smart Review so you don't miss our next deep dive into esophageal cancer management. Thanks for tuning in.